welcome to the We Talk Health Podcast, the official podcast for West Tennessee Healthcare. Please be advised that this podcast is not intended to replace any medical advice. Always follow your medical professional's advice and direction. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions, please reach out to us at wetalkhealthpodcast@gmail.com, and we will do our best to answer any questions you may have.
All right, listeners, thank you so much, and thank you for joining us for another episode of We Talk Health. Today, we are here with our GYN specialists with the West Tennessee Medical Group. We have Dr. Don Wilson, Amy White, our nurse practitioner, and Dr. Jeff Ball. Today, we are going to be talking about contraception. So I will kind of open up the floor. And Amy, how about you tell us about all of our options for contraception, and maybe if there are some that you prefer or you think that maybe some new options that women need to know about?
Thank you. Thanks for having us. Basically, there's several types that women have to choose from. First of all, we start mainly with birth control pills. That's the most common choice of most women. So birth control pills are an option. There's Depo-Provera, which is an injection that you get every 3 months that works very well for prevention of pregnancy. There is Nexplanon, which is a good option for younger girls, teenagers, and young women. It's a little, they call it a bar or a little rod that goes in the arm. That's the slang term for it, but that's what they call it. And it goes in the arm and it lasts for 3 years. And it's very good for prevention of pregnancy. It's as close to abstinence as you can get as far as the methods of birth control that we have. So that's an option, 3 years on that. There's several different types of Iuds that we use for birth control. And then there's NuvaRing, which is like birth control pills, but it's just a little ring that goes in the vagina, stays for 3 weeks, and then you take it out and have a period. So that's another option. It's nice because you only really have to remember it twice a month. Then there is a Tubal Ligation, which is a more permanent form of birth control. We do have a patch too. I'm sorry, I forgot about the patch. We don't use that very much, but it is still an option.
So as far as insurance, are there any differences as far as the cost of these different forms of contraception, or?
Well, fortunately, most insurances cover contraception at 100% right now. Now, everybody's different, and that's not something we always know on the front end. A lot of times we'll get phone calls from pharmacies, and we make, unfortunately, sometimes we have to make our decision based on what insurance covers. But for the most part, insurance covers birth control at 100%.
I think it's a good conceptual way to look at the contraceptive options as well. Is obviously there's barrier methods, phone and condoms, cups, things like that. And then the more what we would call combination contraceptive options that contain estrogen and progesterone together. And those are going to be like what Amy was talking about, the pills or the patch or the NuvaRing. And some women have some contraindications sometimes to estrogen-containing contraception. And then lastly is what we would call long-acting reversible contraception, or LARC, LARCs they're called, which fall into the IUD and the Depo-Provera and the Nexplanon. And those are ones that contain only progesterone. And so for some women who cannot tolerate oral contraceptive or the patch, they can't take estrogens for various health reasons, they can still have some very good contraceptive options on the longer active ones. And those are like the word says, they are longer acting. You don't have to think about them on a daily basis or even a weekly basis necessarily. And those three tend to be as effective as having a woman having her tubes tied, yet they're reversible. And so, and each of them have little nuances that make some better than others in a particular clinical situation, and can be discussed with us as what's really a good options for them, because not every woman is a candidate for all of those options. And in fact, some have some limitations for some patients. But there are many things that women can take for short-term or even long-term contraception that can still be reversible. So they're not doing something that kind of limits them for the rest of their life, like a permanent sterilization with a tubal or a vasectomy would do.
From what I'm hearing, I guess the best course of action would just be to have a conversation with your provider to talk about the best options for you as a woman, because with all of the different things going on, there may be options that are best suited for you. Then with the time frames, I guess, depending on where you are in your life.
Well, in your reproductive life,
Right.
for sure.
Yeah,
And I think that's the discussion that we have with people is what's easiest for you, what's most convenient, what's most cost effective, and what's safest, I think, and we will go over all that on every visit. And it's something we revisit with people on a yearly basis if they're of childbearing age.
And something to consider when Amy mentions safety. You often have to think of contraception the safety of contraceptive methods in comparison with the safety of pregnancy. Pregnancy, while it certainly is not a disease, it's a wonderful time of a woman's life and a family's life and so forth, but pregnancy has its own health risks. And so sometimes people say, oh, I hear that's dangerous. And so they'll forego contraception because they're concerned about potential side effects or whatever. And maybe they've read it on the internet, Dr. Google, whatever. And yet they don't think about, well, I really wasn't planning to get pregnant at this point in time, and pregnancy has its own health risk as well. And so I think those are things that we can discuss with women when they come in about which option might be best for them. So that most women usually have some options, not just an isolated only one choice to think about, and that's a good thing.
What about, and I use this term kind of loosely, but controversy around the IUDs? Can we talk about that? We don't have to go into too much detail, but I have heard a little bit of controversy about that particular type of contraception.
Well, the thing to know about IUDs in 2020, 2021, they're a different form of therapy, because the thing about IUDs now, or the ones that we place, are different in that they're slow release of a hormone that helps with contraception. There are other benefits to that as well that ladies will get, whereas if they're having heavy periods or frequent periods, a lot of times with the IUDs that we use in our office, their periods will get much better or even go away for a period of time that they're on. And so the original IUDs were basically an abortifacient in that a fertilized egg would enter the uterus and then just kind of migrate through because of a foreign body in the uterus. And so the IUDs that we use now, actually, even though they're in the uterus themselves, their contraceptive effect is multifold and in different levels of the reproductive phase. And so from that standpoint, and those were struggles that we all had, I think, as providers years ago with IUDs, and that we made decisions not to use them for that very reason.
Yeah.
And those were discussions we had with retired OBGYNs that were part of Western Healthcare to seek their guidance. And I think that I can speak for all of us. We feel comfortable with the IUDs that we place now. From a spiritual standpoint,
I think obviously all three of us are pro-life, and so those are serious concerns that we don't just take lightly. I think that conceptually the way of looking at not just IUDs, but there's even some birth control in general and birth control pills, and are they abortifacting, and the whole issue. I think you have to look at it in the terms of, okay, is the method that's being used really the only way to prove there are different mechanism of actions of some of these different types of contraception, and you have to evaluate them and say, okay, is the mechanism of action such that it's going to result in the loss of a pregnancy? And the only way to really prove that with these different contraceptive methods would be to show that the pregnancy loss rate, meaning that a pregnancy that actually occurred despite using this contraception, had a higher pregnancy loss rate than spontaneous miscarriage rate. Mm-hmm. Because in fact, pregnancy, human pregnancy itself has about a 70% loss rate. It's a 15% recognized loss rate, but about a 70% loss rate when you count early, what we call chemical pregnancies, those kind of things, that don't actually survive very long. And so you'd have to show that the contraceptive method you're talking about has a higher loss rate in a pregnancy that actually did occur than occurred in a spontaneous pregnancy. And there's no data at all that is anywhere close to evaluating that issue. Right. And so then you have to come down to personal convictions and how you think the mechanism of actions work, and so on and so forth.
And have that discussion with your patient.
Absolutely.
And we do that. Does that kind of help?
Absolutely. Thank you. I know that was...
One thing I want to talk about in our office specifically, Amy has a real gift for taking care of our younger patients, adolescents, teenagers, college-age young ladies. And if you don't mind, Amy, I want you to kind of speak to when would you start somebody on a pill? And I know that varies for each patient, but just kind of your take on that.
Well, I think you have to, when patients come in, they're coming in mainly for birth control, and they'll tell you that. I'm having sex and I need to prevent pregnancy. That's goal number one. And so for those patients, we talk about those options like I mentioned a minute ago. First, basically, we start with birth control pills, and I have to look and think, what are their risk factors? What's their age? Do they smoke? Are they overweight? Different risk factors. What's their personal or family history of female cancers, breast cancers, those kind of things. So it's very individualized, but for the most part, in my practice, we start people on birth control pills. And that's nice in that it is pretty effective against preventing pregnancy, and it helps women to cycle regularly. And so for the topic of contraception, I think in my practice, we use birth control pills the most. And we have a lot of patients that like Depo-Provera. They want the convenience of Depo-Provera. You typically become amenorrheic where you don't have periods. You don't have to worry about that sort of thing. But you have to come to the office every 3 months and get an injection. And there are some side effects for some of these birth control methods. The main one with the Depo being weight gain and irregular bleeding. And as a teenager and at young 20s, that's not high on our list of things we want to happen. So, but that's what we talk about to begin with. So they want to know side effects, what to expect with their menstrual cycles.
I think it's important to understand too, when we have young women come into our office and talk to us about contraception, and this is not the topic of discussion today, but I think it's important for women to understand and get information as well about sexually transmitted diseases, the potential consequences of sex outside of a mutually monogamous, committed, married relationship, and the potential things that can go wrong, such as pelvic inflammatory disease, which can lead to chronic pelvic pain or can lead to ectopic pregnancies. Infertility, huge infertility risk. And so it's not just that someone comes in and, hey, I want to talk about getting on contraception, and we kind of go, okay, all right, let's talk about that primarily. That's what, you're coming to us for our expertise on that. But let's also talk about the choices you're making in your life. And if you're a 15-year-old or a 17-year-old and you're wanting to go to college and you have these plans and so forth, but you're disconnecting your choices you're making in your personal life from the choices you're wanting to make as you age and making career choices and the thoughts of, someday having a family and so forth, and how some of those choices can be limited for you in your later life by the choices you're making right now that you don't think about that have potential consequences. I mean, having sexual intercourse is not necessarily a risk-free endeavor depending upon the circumstances in which you find yourself. And so we try to have those conversations in an appropriate, non-judgmental sort of way about, hey, why are you making the choices you're making? And have you thought through where this might lead you? And you may want to take a step back and reassess. Doesn't mean that we wouldn't prescribe them contraception. It just means we're trying to engage them and let them know we care about them as a person. You're not just a name on a list. You're an actual person whose life may be irrevocably altered by the choices you're making now. And I think each of us have seen that in certain patients. And we can think of certain women through the years who we've cared for who've had a consequence of the choices that they made. And so we try to at least help them get information that can help them think through what they're doing or the choices they're making and the potential upside and downside of those choices.
Right. I like that, we're talking about just looking at the bigger picture. It's not just about not getting pregnant.
Absolutely.
It's about the bigger picture for the health of the woman, and that is individual for every single patient that you have, really.
Welcome to the mind of a women's health provider. It's not as simple as, okay, I need birth control, well, here you go. So we really try to approach it that way. As well.
Well, I think that we're not just talking about teenagers or women these are people in between children, the birth control through the whole reproductive lifespan. But I do want them to feel like they can trust me to talk about this if they are a teenager. And so that's what I try to establish on the front end in a like he said, non-judgmental, non-parental way, but still get my point across that if you make this choice, then we do need to prevent pregnancy, and we do need to prevent sexually transmitted infections. He does need to wear a condom. You do need to have Gardasil, and you need to talk to your parents. You need to have an open line of communication with your parents and with me.
And your provider.
Yes, and absolutely. With me. So it's not just, birth control is not just for adolescents, clearly, but everybody at some point in their life is going to need some type of birth control. And I think they need to be informed and have the best option for them, what's specific to them at that moment in their life.
Along those lines, too, carrying a little bit further, I think not only just for the three of us, for Dr. Ball and Amy and myself, but our office has to be prepared to answer questions that our patients have, or even ladies that aren't our patients that may call to ask about their birth control. Questions like, okay, I missed a pill, what should I do? Mm-hmm. I left my pack at home and I'm at school now, or other questions. And one thing I kind of want to brag on is our girls, our ladies here that have years of experience in answering those questions, and quite honestly, have probably answered those questions a lot more than I have. And we want our patients to know that, whether our existing patients or potentially new patients, that we're not just going to give you birth control and send you on your way. We're here to help you work through those waters too. And just because you start on a particular birth control type, it doesn't mean that you're going to be tied to that birth control either. We're kind of open to Absolutely. Making those changes. Mm-hmm. as well. And this day and time with smartphones and things that ladies have, I will share a little story with you that, as a father of not a young daughter, but a young lady, we as fathers inherit their phones. I don't know if you guys realize that, but like I never have a new phone. I always get the hand-me-down, right? When my daughter was getting married, of course, then not only I got to give her away to her new husband, but she got to give her phone back to me. And I found it interesting in that she had an app on her phone for maneuvering. And I had that phone for about a week or two. And all of a sudden it just started alarming and going off and telling me it was time for me to change my maneuvering. So I share that in that we're constantly being aware of things that are changing out there for our patients. And if a dad has a question, he can call too, and we'll help him work through that as well.
So I have to ask, did it go okay? Did you get it changed?
Well, actually, I couldn't get the app off the phone, and so it reminded me monthly for about 6 months till I traded the phone in. Yeah.
So it was getting very angry with
Right,
you.
right, that's right. And along those lines with maneuvering, you would think that a lot of patients wouldn't like that because they have to change it out every 3 weeks. But for patients that it works well, they love it.
Absolutely. And they don't feel it, which is amazing.
Yes,
I'm
and
shocked.
there are questions like, okay, well, if I'm having sex, what about that? Is it going to affect? They don't know it's there. It's a small percentage of patients, but the ladies that use a NuvaRing, they love it. They do. They really do.
And I think it's important on birth control pills too, because for women to understand, I mean, somebody will often come in and, well, my friend was on this one, I want that one. And I always tell them, I said, well, that's not a problem. It's an excellent pill. But everybody's body is different. And so one woman, your friend, may tolerate that type and you don't, but you tolerate a different type and she didn't. And so you have to sometimes be patient and try to find one that fits with a patient's I say body chemistry, I'm not sure that's the exact right word, but the idea being that the progesterones, the estrogen is the same almost in every pill. It's the progesterone that is a different type, and so those are ones that for one woman they tolerate that particular progesterone, and for another person they do not. And so you have to kind of play with it, but don't get frustrated with it. If that's the type of method you want to use, we can often find one that will work.
And in this day and time in pharmacology, we're learning new names of pills every week. It's amazing. You'll see a patient, you'll write a prescription for a birth control pill, and the pharmacy will provide them with another name. It's the same pill, but it's just under another name. And so that's a dynamic that ladies are having to wade through now. In other words, why is the name on my package changing on a monthly basis, it seems almost at times. And so, we're working through that with them as well.
What are some other conditions that women may have? And we've touched on this just a tiny bit, but I just want to dig in just a little bit more. Other conditions women may have where they could benefit from contraceptive medicine.
Well, we can start young. I mean, Amy, you may want to address this too, but there's a good number of patients that come in to see you that are there because these young ladies are having just horrible periods.
Right, just for cycle control. Mm-hmm. Again, we look at the patient individually, but you start them as young as sometimes 12.
How do they do on
short
that?
term? They do really well. They do really well. I mean, they come back in 3 months, and we just see if it's working at that point or your period's better. And most of the time, you've got the basketball players and the soccer players and people that just don't want to be inconvenienced with their heavy periods, and it works well, and it's safe. They're relatively low doses that we put people on, and it's safe to be on them for quite some time. It's convenient.
Same for cramps too.
Yeah.
Women who have not just heavy periods, but very painful periods. Birth control pills are amazing. Most women. Now sometimes you have to add some other medicine to it, but those work really well. And I think from a parent standpoint, you have to. Because oftentimes, if they're that young and having the parent is brought in, and
it's a conversation.
It's a conversation for sure, and you're trying to reassure the parent. And look, this is not, and you tell the patient, this is not a license to go have sex with whoever you want at all. We're giving you these combination hormonal pills. If you think of them as hormonal therapy, less so as contraceptive, it's easier to call them birth control pills because that's what we're used to. And they do obviously would provide contraception if needed, but the purpose for which you're giving them is for their medical condition. And that can be in their 20s and 30s too for women with someone with endometriosis or other health conditions. They can be very, very helpful.
A lot of the questions that the mothers have are, if you're starting her on pills this early, how's that going to affect her down the line? And quite honestly, there's some good studies show that starting it early from all their health is great, even as an older woman. But I think we spend more time reassuring moms than we do the actual teenagers.
Yeah.
I think there's something that's often missed with contraceptive birth control pills or the treatment of it is there are quite a few non-contraceptive benefits to birth control pills. So women who, while they're having contraception provided, it does tend to make their periods lighter, less risk of iron deficiency anemia because of that, less risk of painful periods, less risk of benign breast disease, helps maintain bone density. As a woman's bone density peaks in their early 30s, it will help maintain that so that when they come into their older years, they have a better bone density than they might otherwise would, and so less risk for osteoporosis, less risk of uterine cancer by 60% or so, less risk of ovarian cancer by 50%. So these are real benefits that women, and those benefits last, particularly the ovarian cancer and endometrial cancer benefits, last for 10 to 15 years after they get off the pills.
They stop the pill, yeah.
So, there are some things now. So we're not prescribing the pills for that reason, but if you're needing it for a medical indication or for contraception, you do get these other benefits that go along with it. And so a lot of patients don't know that or understand that, and and sometimes that can help them be more amenable to the idea of taking birth control.
Yeah, that's incredible, and I think that's important to point out to our listeners that there are benefits other than the obvious.
Back to the young girls, I asked them, how many days a month are you missing school? And some of them were missing 2 and 3 days. And I'll say, there's absolutely no reason we have to do that. We can fix that. We do not need to miss school because of your period.
And then do they get upset with you because you're saying you really don't need to miss school because of
Mother's over there patting me on the back.
Yeah.
But I mean, and that's embarrassing too for girls to have to leave school for that reason. So there's a lot of social, it's just a benefit.
Normally they're quite happy because their buddies are at school and they
Right.
actually want to be at school. Maybe not to learn as much, but to be with their friends. So.
Jeff, I'd like to know, on the other spectrum, too, how long will you keep a lady on birth control pills?
If they don't have a risk factor such as smoking, hypertension that's not controlled, a vascular disease, clotting disorder, some other thing that would preempt us from providing them. If a woman is doing well on her pills, either for abnormal periods or for, which is actually fairly common, obviously, as women get into their 40s, or for contraception, I'll keep them on till about age 50, and then I'll start assessing them yearly at the end of their blank pills to see if they're possibly menopausal. Average age of menopause is 51 and a half or so. I just use 50 as an easy cutoff. And then once they prove to me that they're menopausal, I just take them off their pills because there's no reason that they have to come off at 40 or 42 or 45.
And that's a little different than what we were taught years ago, and that speaks to the lower dose pills that we're on, and the fact that pills have been around so long that we've learned more with that. And to that point, there's a good chance that if a lady's on a birth control pill and doesn't have those risk factors, that we can actually take her to menopause.
Absolutely.
Absolutely. Which is kind of encouraging for them as well. I guess we probably should talk about some of the other forms of birth control briefly.
Well, for the IUD,
we talked about the IUD.
IUD has non-contraceptive indications from the FDA for heavy periods or abnormal bleeding.
And it works great.
It
really works well for our patients. And there are some patients that really have some contraindications to surgery, and it's kind of been a big tool for us to treat that. The one other thing I guess we talked about was the Norplant.
Nexplanon.
Nexplanon, that's right.
Showing your age there.
I'm showing my age. It was called Norplant originally. But Amy, you may want to talk briefly about that.
Well, I think it's a good option. It's easy insertion. We like for people across the board. We like for people to come in for their initial Nexplanon when they're on their period. We just prefer that. But it's easy insertion, quick, simple.
Where's it go?
It goes right here in your arm.
Right on the arm, on the inside part of your arm, right
your upper arm. Yeah, you can't see it. You can feel it, but not unless you just want to. And it's good for 3 years. The main side effect we see with that is abnormal bleeding. And we can fix that. So if you're out there and you have Nexplanon and you're having problems with your periods, then we can fix that.
But don't you find that kind of gets better over time?
It does get better over time. It usually just takes a couple rounds of some estrogen for that. And it's good for 3 years. We can take one out, put another one in, and it works really well. Don't have to think about anything for 3 years.
Yeah, that's a similar side effect with Depo-Provera is the abnormal bleeding. About half of women who are on Depo will have no periods after 1 year of use. The other half will have some irregular spotting or bleeding. If those same women stay on it a second year, it drops down to 20% have some irregular spotting or bleeding. The other 80% do not have periods, and they really like that. The problem with Depo-Provera is there's a black box warning about potential impact on bone density. So after 2 years of use, you have to really You ought to be on some calcium and vitamin D if you're going to take Depo-Provera. If you're taking it now, you need to be doing that to help prevent bone loss. It is thought to be reversible when you quit. Not 100% sure of that, but we're highly likely that seems to be the case. But that's why they have that black box warning. So after a couple of years of Depo-Provera, you might need to change to a different option depending upon your clinical circumstances. But it's a like I said, Depo-Provera, Iud, and the next one on all basically are equally as effective as if you had your tubes tied, yet they're reversible. So
To that point, two things we haven't talked about as far as contraception is tubal ligation, and that's probably for another podcast. And then lastly is vasectomy. We do not do those.
Women's health.
But I do want, this is women's health, but I do want to speak to the ladies out there who have had that conversation with their husband. I always just encourage them when they come in, I said, don't die on that hill. If you've got to drag him to get his vasectomy, screaming and kicking, then you're going to pay for that for years. You're going to hear about it. Well, I had my vasectomy, even though you had 5 babies naturally without an epidural, but. So don't feel alone if your husband is really balking at the thought of a vasectomy, because most of us do.
that's true. I'll just say
And on that
that's
note,
The best way to just package it as doing it during March Madness, right?
Right.
So,
there you go.
There
so
you
while
go.
they or the Masters or
Right.
some other thing.
That's right.
some
That's
other
right.
activity that will give them something to do while they're recuperating.
That's right.
That's right.
But for young wives out there, just choose your battles.
Good advice.
Right.
Good advice.
come see us for your tubal.
That's right.
There you go.
And remove apps from your phone before you pass them down to your father.
That's,
That's
right.
right.
Lots of
That's
lessons in this.
That's right, Katie.
Lots of life lessons here. So we're here to educate the public. That's what we do. So, all right. Well, any other thoughts on contraception today that we can share with our listeners?
I think we
Covered
just
a
wanted
wide.
If they have a question, call us,
Yeah, absolutely.
and we'll find that answer.
Our number here at the office,
Correct. Go ahead.
731-660-3344.
3344, easy to remember. So, and all 3 providers are accepting patients. So, if you are looking for a women's health provider, please give our GYN specialist a call today. All right. Well, thank you,
Thank
Dr. Wilson and Amy and Dr. Ball. We appreciate, as always, having you. And thank you, listeners, for listening to another edition of We Talk Health with West Tennessee Healthcare Medical Group.